Recently, the Society for Vascular Surgery decided to create an audio-video archive of interviews with those who have contributed the most to our specialty of vascular surgery. Dr. Jimmy Yao is chairman of a working group, as we call it, scheduled to interview our famous and distinguished colleagues. My name is Norman M. Rich, and today I have the privilege and pleasure of interviewing a legendary surgeon, Dr. Ronald J. Stoney, who I have known for somewhere around 55 years.
Right.
So it's a privilege again, and let me say, Dr. Stoney, we appreciate your willingness to be interviewed.
I'm honored and delighted to be here.
Knowing that you were born in Carmel,
Yes.
would you please tell us a little bit about your early childhood and possibly if anyone influenced you to become a doctor and specifically a surgeon?
Sure. I was born in a hospital which had been a retirement area for people with TB and other illnesses. They turned it into a hospital, and I was the first boy born in that hospital. March 4th, 1934. My dad, a building contractor with his brothers. My mother was actually very, very talented as a seamstress and did an awful lot of work in that area for I. Magnons and also for other women's groups. So one sister came along a year after myself, and the four of us were in Carmel till about just after the Second World War, 46. My dad was very interested in moving a little bit away from the fog in Carmel, which is a great summertime distraction for a lot of people. So he would go up the Carmel Valley Road on a weekend, trying to figure out where the fog wasn't or where it actually left the ground before it was still foggy in Carmel or whatever. And 11 miles up the valley turns a little bit south, and the fog doesn't really follow that curve very well. So he bought a house, bought a lot, 5 acres, looking up a beautiful Vista Canyon off the highway, off the road. And we moved there in January of 46. Building contractor, he built the house himself. Adobe, great home. And we spent then our time from there until both Sue and I went on to college. But the valley was great because it was outdoors. It was the streams to fish, the hills, the mountains to hunt. And I worked every year on cattle ranches and for a farmer. So it was a great way to kind of get introduced to the outdoors and a few other things, and besides just the Carmel mode, which a lot of my friends, of course, did move out of Carmel, so have a little bit different style there.
No doctors in your family, though.
No doctors in the family. My dad, as I say, carpenter, building contractor with his brothers, but no. Most people didn't actually have a college education. My dad had 2 years of college. He was one of 10 boys and 2 girls from a Mormon family. 5 boys died before the age of 1 year.
Oh, goodness, yeah.
And when they grew up and they moved to California, they were anxious to be out here. Everything was great, but the Mormon, I guess you'd say, mindset for education was the oldest son. And the oldest son, my Uncle Lyle, was educated at Brigham Young University, was an architect engineer, and he actually was one of the main people in the Stoney brothers business. So that's what it was. And my dad, as I say, my mother finished Lowell High School in San Francisco. My dad 2 years at Brigham Young, but that's it.
Well, knowing your interest in ranching, is that why you chose Santa Clara, being called the Broncos?
Well, it's close, but when I was getting ready to get through high school, I'd had a very interesting experience in high school. Second year, there was an option for us to choose. One of them was typing, and the other was biology. Well, I still haven't learned how to type, but I did get into biology. We had a wonderful teacher who actually stimulated myself and one of my close friends, also lived in Carmel Valley, Jerry Robinson, and we took this first biology class, and then we urged her to help us for the second class, and then finally a third year. So the last 3 years of high school we had had biology. And we did some things that probably most people wouldn't do. We both of us collected snakes at home in the valley. So we would take these snakes, euthanize them at the lab at the biology class, inject the arteries with red and the veins with blue, and then dissect them. Had some really great times there. He went on to be a PhD scientist at the NIH, and I came in this direction. My dad was very helpful to me, and my mother too, saying when I was getting near high school age, did he want to start up the construction business? Because I've been helping him a lot on that. He says, no, son, he said, you really need to follow your God-given talents. And he said, they probably ought to start by exploring the educational and intellectual side. If that doesn't work, then you'll be in some technical area. Two things happen when you find what you do and you pursue that passion. You do a good job at what you do. And secondly, you're happy doing it.
Sure.
So
how did you end up at the medical school at the University of California, San Francisco?
It was luck, I guess I would say. I applied to all the schools, including Stanford, which actually didn't take me. I couldn't have afforded it anyway. But I got into USC, got into all the Jesuit schools, and never heard from UCSF until 2 days before Christmas, 1955 would be 54 would be my last year of college. And I got a misaddressed letter to me from UCSF announcing that I was admitted to the class. So I went from Carmel, Santa Clara to UCSF. So I haven't traveled too much since, actually.
Who was the first surgeon you met that had an impact on you, I guess is the best way to ask it?
I would say probably Dr. H. Glenn Bell, who was recruited by Howard Nafziger, a world-renowned neurosurgeon, and he recruited Bell from Cincinnati, trained by George Hoyer and Mont Reed, both Halstead residents.
Right.
And he came out and really established the general surgical program, which Nafziger really wanted that done. So I think Bell, a master surgeon, to me, I got to take care of a lot of patients with him, operate with him a lot. And I think I got the idea from him, maybe that I didn't get from some other surgeons, that I really needed to pay attention to how he thought as a surgeon, because that was what directed him. And it wasn't just like tying a knot or just like pushing tissue one way or the other. I mean, he had a plan. He was an interesting surgeon because he was the first medical school in California, first department of surgery, and he's the first general surgical chair. And his job was to train the best surgeons he could for California. So they went to all these major centers from the Tehachapi all the way to the Oregon border. They did great surgery because he trained them, but reoperations came up, cases that they'd never seen before, resources in the community that they couldn't handle with the local hospitals. Those patients came back to Dr. Bell. Yeah. So we went to one other level of really complex, challenging, not entry-level surgery. And I think having that experience with him, and then, of course, Jack Wiley after him, really, I guess, convinced me of how you could become a surgeon, particularly if you work with a master surgeon on challenging cases rather than just the entry-level stuff.
I remember Dr. Bell very well, too. You and I both ended up out at San Francisco City and County Hospital, as it was called at that time,
right,
as you'll remember.
Yeah.
As medical students on Cal and Stanford services, we also worked with residents in each other's programs.
Right, exactly.
And did you ever run across F. William Blaisdell, one of the senior residents at Stanford?
Yes, absolutely. Oh, yeah.
Well, that's why I asked, because,
Sure.
Again, Dr. Blaisdell was like a big brother to many of us, and we really revered him, and that certainly continued the fire in our interest in being a surgeon, but probably even gave us a little bit of a start toward vascular surgery.
Oh, yeah, very definitely. Yeah,
You also did a rotating internship.
I did. I went to San Francisco General to do the internship because I thought I was probably going to be a general practitioner / surgeon, because at those times a lot of general physicians did surgery, some for surgery, and that's where I thought I was headed. My internship year was 59-60, and when I did that year at the county, the Stanford service had moved from Clay and Webster to the farm, and 16 of their 32 interns didn't match there, and we matched 32, so we had 3/4 of the interns in the hospital And I got to rotate on several Stanford services as well as our own. And, a number of people said to me, maybe you ought to go back and see if you can get back into UC surgery. So I was lucky enough to get back in. And I'm sure that experience there was very helpful to me to try to redirect myself towards surgery.
That was a very tumultuous time for all of us in the Bay Area, no question about that. We don't have time to really dwell on that, but when did you first meet Dr. Wiley, Edwin J. Wiley?
Edwin J. Wiley?
Yeah, when did you first meet him?
Second year, a medical student, he gave a lecture at the county along with a number of other professors or faculty, and he was talking about obstructive disease of the vessels in the lower extremity, PAD, you and I would call it. And I remember him talking about it, and I took some notes, which I still have actually, about, the sense as as a vascular surgeon specialist, to be cautious about the surgery in this area to improve circulation, because sometimes the operations start out well and they don't actually end up very well, and sometimes you convert somebody who has mild symptoms of vascular insufficiency to losing a leg. So he was, I would say, conservative or cautious, but definitely kind of got my attention. So that's when I first started.
He also, from the beginning, taught you the value of international exchanges, and we'll talk more about that a little bit later. But Sid Dos Santos was one of his great all-time friends.
Yep.
And would you comment about what effect you think Dr. Dos Santos had on Dr. Wiley?
Well, I think Dos Santos certainly was the first surgeon that we know of that ever was able to actually remove the plaque of a blood vessel. We now call that endarterectomy, or removal of the lesion, and restore circulation. And that led Portugal, 1947, and that led to the development of that as an option for treating people with obstructive vascular disease. And Wiley then it went to France, and Lariche there in France was doing it. They started to do, instead of the extremities, they started to do the aorta, and Jack Wiley, of course, popularized that and introduced that in America with his first aortoiliac endarterectomy, removing the disease, 1951, and that sort of set him on a pathway. And the last thing I'd say about Dos Santos is, in 1974, he visited our hospital and our vascular service, and we had a great dinner with him that Jack Wiley and his wife Clea put on at their home in Belvedere Island. And at the meeting, I started to talk to Dr. Dos Santos about how would it be if he were to come to the vascular meetings next year, and we'd have a sort of a dinner meeting and maybe recognize Jack Wiley. He said, I'll do it. So he came, and he was terrific, and he gave this remarkable address to Jack called Homage to Wiley, and delivered it at this restaurant, this lovely Anthony's Pier 4, a restaurant down in the waterfront there in Boston, and we all had a great time, and that was the beginning of the Wiley dinner and eventually the Wiley Society. But I think Dos Santos had a great impact on Jack, and also they had more times together than I'm recording for you, but excellent people.
Well, to be in the same institution with somebody who was really on the cutting edge of an exciting, developing new specialty must have been very invigorating for you. And you were very fortunate to be able to stay through your training and then remain. And would you mind sharing with us how you and Dr. Wiley decided that after your training you should stay and work with him?
The short answer and the long answer, it probably was, I was very much more committed to, besides general, to vascular surgery, and I had had a lot of support from the faculty. And when I got towards my senior year, I was planning to go to Monterey and practice general and vascular surgery. And I took a month off in July, went to Houston, and I had a letter from Dr. Wiley introducing me to Michael DeBakey. During the month I was there, I never got to meet Dr. DeBakey because he was too busy, but I did work with Crawford and Cooley, and I mean, it was fantastic to see these people. I met that in my 3rd to 4 weeks there, and I get a phone call from Dr. Dunphy, the chair, and said, we'd like to have you, Dr. Wiley, and I'd like to have you come back and take a year as their super chief or administrative chief president and see how that goes. And I said, well, I could do it till January, but I said, then I think I'm headed down to Monterey. Well, he said, let's see what it's like for 6 months. So actually, the 1st of August, really, I started as an instructor on the faculty. At the end of that year, I stayed on as an assistant professor, and the rest is history.
Well, again, fantastic opportunity, but
Great
such
opportunity.
an exciting time really for you.
Oh, yeah.
You know, the vascular fellowships mean a lot to all of us, and we know that Dr. Wiley is given credit appropriately for starting the first.
Yeah.
Would you tell us a little bit about that? Because you were quite junior in your
Right.
training when
Yeah.
he started the first vascular fellowship.
Yeah. My fellow residency started 59, July of 59 to 65. But yes, the thing about that, I think, was we had first we were just part of a general surgery floor where there were vascular patients. Then there was a vascular service. And eventually in 61, 62, that really turned into more of a division status. But that's the same time that Wiley established the first, as far as we know, vascular surgical, service, and also the first opportunity to train general surgeons in addition to general surgery in the specialty, if you want to call it, vascular. So I was second-year resident. Malcolm Perry from Dallas, Texas, was our first vascular fellow, and spent a year with us. And we've been friends, of course, ever since, which I have with almost all the fellows. But that was a great time, actually, to see, if you will, the shifting from just the paradigm of a general surgeon / vascular surgeon, which was the typical style at that time, to a general surgeon, and then advanced training. Fellowships were not really very popular then, or hardly any, and to make that move. And of course, Jack envisioned that, I think, because of two things, but the most important was he was a doctor that was interested in delivering the best possible care to people. And when he saw that the surgeons he was training with limited rotations on vascular were not being able to really, I guess you'd say, adhere to that standard that he set, a very high standard, the idea of how do we improve that? And we can't do it in the residency, so that led to his, paper, which you want to talk about later, but his address, and that has really set the way for the specialty, if you want to call it, as emerging.
For all the reasons, Ron, that you mentioned, I remember Dr. Wiley very early in my career telling me how when he first thought about the vascular fellowship, he was going to train about 8 a year. But he said it didn't take him very long to realize that all the people he was training were thinking about setting up a private practice within a 10-mile radius of him. So he figured it was better to scale it back. Do you remember his comments about that?
Well, yeah, I do. I mean, he was thinking in the bigger picture about how could you really broadcast this. But I think one of the influences might have been Dr. Bell, who trained, you might say, a surgeon a year, and they went out to the communities and they sent back their complex cases. And what he wound up doing was being a little bit more selective. One fellow, a lot of them were local, of course, originally, and then they branched out. But again, he got some of the same pattern of referral of complex reoperations, things like that, that no one would normally get. And that's the way that's the standard he set for practice at UCSF, and it's continued. I think my practice was the same, and I think it's continued to this day.
We remember Bill Ehrenfeld and you were kind of Dr. Wiley's two lieutenants. We know that Dr. Ehrenfeld's no longer with us and can't be interviewed. Would you just say a few words about his relationship with you and with Dr. Wiley?
Bill did the vascular fellowship the year I was on the faculty, my first year. And when he finished, he came on board as well. And Bill had been trained in New York, very interested in vascular, came out and did the fellowship. I guess he was the fourth fellow after Malcolm, and had a real interest in the field. And I was on board, and they invited, in fact, Dr. Wiley mentioned to me, he said, what do you think about inviting Bill Ehrenfeld to come on board also? We're trying to really build this service. And so that was great. So Bill joined us, and we had some great times together. William K., I used to call him, and he used to call me Ronald J., and did a lot of stuff together. And he did a little bit more in the lower extremity and hemo access than I did, But basically, we did a lot together, wrote a lot of papers together. I think one of his major independent contributions away from me was he and Jack Wiley wrote this book on extracranial cerebrovascular disease, which was a treasure at that time.
Before we get into the written contributions that you've made and so forth, let's stick with the fellowship for a minute and just say, with so many fellows that you were involved with and helped train, are there any that you've been particularly proud of?
Well, I guess the answer would be yes. I don't think I'd want to actually name them because I think part of being some of the really superb surgeons, gentle people with patients, etc., I'm really surprised at how many, some that actually might not be in my top echelon or tier, have made some really surprising and sometimes bold, novel, innovative moves in leadership in surgery, in research, in patient care, and it's been exciting for me just to see how this nucleus of people trained at UCSF to follow the paradigm that Jack Wiley set up, how well they've done in this country, Canada, and South America, Europe, etc.
Well, healthcare delivery is what it's all about, and some of them who didn't go academic, if you will, have really been superb. And from Mac Perry, who had been an Air Force intern at Letterman Army Medical Center, if you will, to 6 or 8 that I can think of from the military who you trained over the years. We've all been proud of all of them, and appreciate that very much. So that's a good part of the fellowship. Let's do look ahead a little bit and talk about what was beginning to happen in the late 60s. And I remember you asked me to come along with you to the wharf in 1970, and we sat with Dr. Wiley, with Dr. Ehrenfeld, and maybe a half a dozen other people. And the reason that remains embedded in my brain so much is that Dr. Wiley was using us somewhat as a sounding board for what he was going to incorporate into his presidential address to the Society for Vascular Surgery. And I'm sure you had a lot of discussions with him at that time. Would you share a little bit of that with us?
As I say, it all stemmed from the idea of, what kind of health care could you deliver and what did a patient deserve as far as health care, particularly in the vascular arena. And the experience that he had, sort of the same that Dr. Bell had in general surgery, with these people going out without really being accomplished enough to handle some of the problems, led to the idea of a more expanded exposure. During the residency, we did at first have more assistant residency exposure rather than just maybe 1 month and then as chief resident. So that was one difference. But I think eventually he just talked more and more about, we really need to make a change here, and we need to help develop. He wasn't talking about like he was doing it, like we could develop. And I don't think we was necessarily Bill Ehrenfeld and I. We were he had a great camaraderie with many, many leading surgeons around the country. And it all sort of came to a head. The paper was delivered, Vascular Surgery, A Quest for Excellence. And in 10 years, he and a great group of active people put together a package that the American board accepted, and we had our certificate of competence in vascular surgery 10 years after he gave his paper.
I can always remember him saying that he wasn't really proposing another examination in the early years. Obviously, it ended up being that way. Well, and that's the way things go, as we realize and everything. But do you have any additional thoughts about that?
Well, I think the one thing about his idea was to improve and concentrate the training in the vascular surgical area was important. But I think beyond that, he did emphasize in his paper and his presentation that we do need to set standards by which these trainees will perform and be expected to perform, and then we need standards for the actual fellowship hospitals and the people that are running them. So to me, it was more the complete package rather than just, well, we put this guy out here for a while and maybe he'll get better. So it was a very rigorously organized, stepwise approach to. You had to measure the result, and you also had to, we had this committee called the Peak Committee Program Evaluation Committee. Anyway, that was really important, and to him, and I think it helped us, all of us, realize as the academic, people mainly in the United States move forward, that this was what we would follow, and serves us well today.
We know that Dr. Wiley had a premature, unfortunate death at age 63, which gets younger every year for people like you and me, doesn't it? The reason I ask that is that we know that through the late 80s and the 90s particularly, we had an unfortunate division in vascular surgery with among a number of our good friends, all trying to do the best through their own vision. But do you have any insight into what you think Dr. Wiley might have thought about all of that? Do you think he would have favored an independent board for vascular surgery?
Well, I certainly think in his idea of the presentation he gave, his address, I think that would have been maybe one option out there, but it certainly wasn't the way he had planned it. I mean, no, to be like thoracic surgery, had just a little bit before that, had actually moved away from general surgery, had their own actual specialty. I think he really, because he came from Dr. Bell and a general surgical background himself there, still felt that it was rooted in general surgery, but it had taken on a life of its own in a way. So to me, and to the way he thought about it, at least that I understood, we weren't really sort of arbitrating for a particular specialty, independent board, etc., but more a collaborative with the American Board of Surgery, which was the oversight for it, and yet within that we had a vascular, representation would be the best.
Well,
way.
we do recognize too it's a little bit unfair to try to ask about something in past years, particularly when general surgery isn't the general surgery that he, you, and I, and Dr. Bell and many others knew. Right. So times change. This interview is really about you, but one of the reasons we brought Dr. Wiley in early, and we're glad you talked about it, is because you were a team and you were so much a part of an effort complementing each other. He couldn't have done what he did without you and without Dr. Ehrenfeld, as we know, but you later became president of the North American chapter of the International Society for Cardiovascular Surgery and provided very effective leadership on your own. What do you think at this point about the joining of the two vascular societies in the United States in 2003?
I could see you might say, a benefit that would be derived by being more unified in the issue of, let's say, the vascular surgeon specialist and the healthcare delivery for the threatened patient. But the thing about that always confused me was, and I never did really, still don't quite understand it. It was sort of there was a pairing, if you will, of the membership. There was a distinguished fellow, and then there were the also-rans. And I myself didn't like that idea of having two classes, if you will, of citizens or membership. I guess as time has gone on, maybe that issue has weathered the storm, but to me it was not, I really didn't think we needed to do that. I think we could have had within the two, or else organize the one society that had a little bit of a different respect for any member that joined.
Change always creates a certain number of challenges. On the positive side of it, I think that we have moved along far enough, and it's almost like the academic advancement from assistant to associate to professor, much like in the military where you go up in rank. I think most people have accepted it that way, and I think it has been very positive.
No question.
I think it's really unified us after all those horrible times when we were house divided. Along those lines, and much out of your experience and my experience, do you have any thoughts about the 0 and 5 vascular fellowships started in 2006 and are expanding rapidly?
Oh yeah, right. I think the one side of the coin, of course, is it does tend to emphasize more and more the sort of the specified role of training in vascular surgery. The one thing that I always have felt was a great foundation for vascular surgery, that is general surgery as the foundation, was that you got exposure to some areas of surgery that possibly you wouldn't in just a pure vascular environment. and trauma was the main thing. And Bill Blaisdell, you know, a great leader of ours at UCSF, Level 1 Trauma Center at the county, and go on and on, all the people that he trained. I think that was a great experience to have coming from a surgical background and then entering that field. Not that you had to do that every day, but certainly I think that was an important ingredient that I'm hoping can still be to some extent preserved. But when you get down to these very, very restrictive, I guess you'd say, patterns of training, that would be one of my concerns.
Well, you know, you probably can reflect too, Dr. Bell, Dr. Goldman, Dr. Matheson, many of the people like that telling us that they were sorry that we missed the golden age of medicine. Now we're telling the younger people behind us that we're sorry that they missed the golden age of medicine.
Right.
And yet it's a very exciting time.
Oh, yeah, very exciting.
And many, many changes. And so much of vascular now is endovascular and has become catheter-based. So it really has changed the whole scenario. And, you know, somewhat aligned with this and the trauma end of it is the new development of acute surgery. And that seems to be pushed more and more. And that may fill some of the developing void. But, you know, I think one of the things we're all concerned about is that the young people being trained today just don't have the open operative type of exposure.
Yeah, no.
On the international scene, we've already alluded to the fact that you had some early exposure to that. You certainly traveled extensively. You've had many awards and recognitions, and yet you chose some very delightful places like Sydney, Australia, to be a consultant at St. Vincent's and that type of thing. Reflect on that a little bit and tell us a little bit about your experience there.
In 1980, there was an opportunity for a sabbatical, 3 to 4 months. Jack Wiley was kind of opposed to me doing it because we were both very connected with Australia. They would come and visit us. We all had been there before several times, and he was actually inducted into their Australian Vascular Surgical Society. So we had some great trips, great relationships. But when I wanted to go back there, he said, "You know, Ronnie," he said, "your practice is really come up a great deal, and maybe to spend that much time there, you might lose a little traction here, and maybe you want to rethink it." Well, anyway, I convinced him that we should go, and it was a great experience for me. The hospital, the chance to visit every capital city in Australia, the chance to interact with people there, and two people that were very important to me as time went on. One was a vascular medical specialist and researcher trained in medicine, vascular medicine at the Mayo Clinic, who was on the faculty at New South Wales. And another was a plastic surgeon turned urologist, name of Turner Warwick from England. And both those people had some effect on me. In the first case, I was, you know, I might say, interested in talking with my colleague about vascular medicine and research, the idea that instead of being at the sort of treating the end stages of many diseases, the aneurysm is about to rupture, the stroke has happened, the leg is probably lost, could we get at an earlier stage and be able to impact the care and treatment of patients? And one of the words that came out of that was, well, research maybe under some circumstances might put us out of business as surgeons. But that wouldn't be so bad, actually, if it transformed human health the way it did. So that gave me a start for the foundation later on, and then Research Foundation. And then my friend Turner Warwick, he did very complex operations, mostly for straddle injury in males where they had the urethra all. And he would do these procedures, came to Sydney every couple of years, and they'd have a dozen cases lined up, and he'd do them. He developed his own self-retaining retractor system that he used. And I watched him do some of these operations, and I said, you know, that would be a great idea if we could adapt something like that to some of the deep, complex exposures, let's say the aorta and its branches. So I asked him if I could use his one day on a case I was going to do with one of my colleagues there, a renal artery aneurysm. He said, sure. He said, I'll watch you set it up. So we did. And I did it with Tom Nash, my great friend. And the intern and resident stood on stools and watched the whole operation without breaking their backs trying to hold the retractors. So that kind of led eventually to moving in that direction of retractors. I had a great time in Sydney.
Well, out of that, you developed a worldwide reputation for your work with the Iron Intern, as many of us called it. And there were a lot of junior people in training who were extremely grateful to you.
I'm
And
sure.
today, do you still see advantage and value in that for the open procedures that are,
Well,
are done?
yeah, I would say also some of the open procedures we talked about it. Some of these are going to be demanding procedures because of the condition of the patient, let's say, risk factors, and also because of the complexity of the problem that can't be solved with a catheter-based therapy, or the catheter-based therapy fails and it takes maybe a master surgeon to be able to solve the problem. I feel myself that the retractor system was great because we started it. My very good friend Bruce Levon, an engineer from Minnesota, and had some experience with retraction. He developed a retractor for the cardiac surgeon to lift the left hemithorax up under the sternum so he could get the internal mammary out. And then we started this program together, OmniTrack, and I thought he was great because he really spent a great deal of time in San Francisco with every iteration we did of this, and eventually, of course, it led to a retractor that was very adaptable for vascular surgery. But now when you look around and see what they have, the transplant people have them, spine surgeons have them for anterior exposures. I mean, it goes on and on. And we started, Bruce and I, in a two-car garage in Minneapolis. And when I went back for a great visit in the early 2000s, 2004 or 5, we were hosted at their new facility. They bought a 4-acre plot in a business park. They had a lovely little pond where the mallard ducks were swimming around. We drove up to this 55,000 square foot building, which was the thing. Of course, it was nationwide, North American wide, and of course worldwide. And so I think it's helped a lot of people.
Well, you can be very proud of that. And for the historical interview, we're very pleased to have this reflection from you, because everybody recognizes that you are the innovative factor behind this. Before we leave Australia, there were a number of Australian surgeons who you trained in the fellowship, from Reg Lord to David Effany to Robert Lusby.
Right.
So
one more thing, maybe just about Australia in a sense, and back to Jack for a minute. I think he was very interested in encouraging and also himself traveling to learn more and advance his own understanding. And of course, the visitors that came to us advanced their understanding of what vascular disease and vascular care was about. And he had many travels. I had quite a few also. But the number of people that came to us, often they weren't in any kind of a fellowship role. They came to watch and visit. And one example was a friend of mine from Ferrara, Italy, Francisco Mascali. He came, Dr. Wiley had passed away by then. He came in the 80s, spent 6 months in San Francisco, didn't have a license to operate, watched every operation that I did or some Bill Ehrenfeld did, and went back and started a very innovative vascular center at University of Ferrara, where he has really transformed that area. And I think that happened in a lot of places, and I think we're grateful that the idea of actually traveling, using that as one of the ingredients for advancing your own understanding of things is a great idea.
we both have been lucky again to have mentors who believed in that approach.
Yes, absolutely.
Over the years, what do you think about our standing in vascular surgery among the leading nations of the world? Do you think that we're equivalent, ahead, behind, or do you have any thoughts about that?
Speaking for this country, I think the cardiologist and the interventional radiologist have taken on a role in this that in some ways has maybe dwarfed the vascular surgeon, and there's a lot more interest now in the word vascular specialist who could be a surgeon, but he could also be a cardiologist. And of course the radiologist, who normally looks at x-rays and doesn't see patients, is now also in that game. So that's a little bit, I think it's a little bit concerning to me. How much that applies in other countries, I don't have enough experience to know. I know some people in a number of countries that are very, very skilled and very expert in endovascular, and they are vascular surgeons that I know, but I don't really know that intermix of the other specialties in medicine, and particularly in the vascular system, like the cardiologist, for example. So I think that's probably still an issue.
In the early history, you mentioned not only Dr. Dos Santos, but Dr. Lariche, and there's certainly many other important contributions to our early development. And I think with the friends we have, and much like your experience with your colleague from Ferrara, they continue to do very well too. And as we go back and forth, we appreciate that nobody has the patent on knowledge or what's being done.
And I think that's really a generous statement, but it's also, I think, very healthy. Worldwide, I'm talking about the people that are threatened by this problem that really do need this to encompass a global impact rather than very focal.
One thing the statistics tell us in recent years is that statins have had a phenomenal impact on decreasing the number of patients with carotid artery stenosis and with abdominal aortic aneurysms. In the FDA, I know they said this is the closest to a miracle drug that has been developed.
From my own understandings, I mean, definitely it's advancing, I guess I would say, the overall scope of care and treatment of patients with vascular disease. You mentioned, the cerebral vascular situation with stroke and the heart itself. I think that you see glimmers of this in other areas as well, peripheral arterial disease. And I think the idea of actually being able to address inflammation, which is the issue in obstructive vascular disease, the intimal plaque is, of course, is a manifestation of inflammation and scarring. And I think to be able to modify that in any way, I think is helpful. And it helps you gives a little bit more to the, I guess I would say, to the important but sort of auxiliary modes of treatment. And I think when they're combined with other aspects, other interventions, whether they be endovascular, open, or whatever, I think it's beginning to show more and more that we're keeping more people alive longer with the same threatening problems, because statin does have, besides other innovative treatments, does have a role.
You certainly have many things of which you can be proud. I know one thing you're proud of is the foundation that you started in 1982 that now you call Vascular Cures. Would you tell us a little bit about that, what led you to develop that, and where you think that's going?
Well, it started in Australia with the idea that I talked to you about earlier, the idea of research, being able to discover new ideas from research that would actually translate into better and better improved care of patients. Maybe getting to the stage at some point where instead of just improving care, you might even be able to do some prevention, which would be maybe the ultimate cure. So that was the mindset in one sense. When I came back, 2 years after I got back here, I had the chance to operate on the owner of the Oakland Raiders, Wayne Valley, and he had been several times to Houston, Texas to have surgery for aortic obstructive disease. And when I saw him, he'd had 3 operations, and they'd all failed, and the last one caused him to have a bowel infection because the plastic had eroded into his intestine. And so I took care of him, and he did well. And he came back to me at about the 3 months mark and complained a little bit. He said, I got your bill, and he said it was for $3,900. I said, well, that's the relative value scale we use. Is that a problem? And he said, well, no. He said, but he says the other problem is that I got a bill from the hospital for 13 hours in the operating room. He said, were you in there for 13 hours? And I said, no, about 12 and a half. So he says, you're working for $300 an hour, and you saved my life. And I've got attorneys that spill their lousy cigar ashes on my carpets, charge me 5 times that much. They don't save me anything. So he says, what are you doing in your field of vascular surgery? I said, well, academic thing here. He says, anything you want to do? I said, I'd like to start a foundation. Wrote me a check for $100,000, told me the attorney that would incorporate us, said, when you need more, let me know. So a grateful patient and someone that could make a difference, and that's what's got us going.
Well, a fantastic thought, but again, it was your innovative efforts that really led to that, and we know that it's expanded. We know that you've been able to provide financial support for a number of young investigators who, in their own rights, have done extremely well, because I've been to a number of your annual recognition dinners, if you will, to see what people are doing, and I think it must be very, very satisfying to you both personally and professionally to see this. Do you have some thoughts that you wouldn't mind sharing with us for the future?
Sure. I would say that the step we took to get there was we called ourselves supporting research projects, and then with the wisdom of Gene Bernstein, who's no longer with us, the idea of investing in people, not projects, led us to this Career Development Award you mentioned, the Wiley Scholar Award, and that gives, I'll use the word, a 3-year, $50,000 per year award to a young, promising surgeon/scientist to help them move from the dependent state they're in to independence as an investigator. And as I say, you've been to many of our Wiley dinners and have seen a number of them, and they continue to, I guess I would say, take on extremely important roles in the vascular world for sure. Academic, they go from being assistant professors to professors and chairs of division, etc. They have their research has become so well qualified that they have funding from national agencies. They're independent investigators. They mentor other scientists, and we've had four now Wiley scholars that have been mentored by another scholar before. So I think it goes around, comes around.
Yeah.
It's pretty exciting, and I think it's an important thing to invest in young people to help them bridge some of these gaps that are obstacles that they have to overcome.
Before we get to a few questions that might sort of wrap this up for us, let's reflect back for a moment to a very enjoyable meeting that you helped host in Carmel in 1972. It was the joint meeting of the two vascular societies, and you were very gracious in inviting a number of us to your ranch. Tell us a little bit about that ranch and what reflections you might have had subsequently about that event.
Well, it was an interesting time. First, because the vascular meetings were held in Carmel instead of one of the typical American Heart Association, American Medical Association sites like San Francisco, Chicago, New York, etc. And they moved to another site. This time it was Carmel. Bill Blaisdell and I were the local arrangements chair for the thing. And during that, we invited people, if they wanted to come out, get their hands dirty a little bit one afternoon. So we put together a barbecue at the ranch. It's about 40 minutes from Carmel, and we organized ways that people could carpool, and we had a couple of larger vehicles that they could go in. And we had over 100 people came for the barbecue, and Jack and I had a lot of fun, kind of hosting it in a sense, and he carving meat, and I sort of telling him I think carve. Anyway, we had a great time there. I had a lot of great friends that had reminded me over and over again that one of the real sort of sideshows at a vascular meeting that they really enjoyed, and I love to be able to have done that and give them another little view of the world.
In your career, you've been recognized a number of times. Is there anything that has been particularly special to you? And let me prime the pump just a little bit and say we do recognize you received the Lifetime Achievement Award from the Society for Vascular Surgery, and we all recognize that's really one of the pinnacle all-time recognitions. But other than that, or with that, is there anything of which you're particularly proud?
Well, I mean, I'm humbled really by some of the, I guess you'd say, some of the recognition that I've received, and I feel each one of those awards in its own way is sort of very special to me, and I think if it helps, because I've been given this honor to, I guess you'd say, move things forward in terms of the area that we're interested in, helping people with vascular disease, I'm good with that. There's some other great people that are also in that same league of people, and they're many of them great friends, and I think in different ways they've made impacts that have really helped our specialty, and that applies mainly in some sense to to the SVS medal. Chance to be involved with Santa Clara University, where I received a doctorate. My own alma mater was great, and I've been somewhat involved there with some of the work of the students with in the biology area, which might lead to scientific careers. So they've all been very special. But a lot of other people were running the same game as I, and they could have easily got it instead of me. So.
Well, again, we're fortunate to have lived long enough to see a few of these things come around. But tell us about your tie, since you have an aortic arch with some branch vessels off your tie. Tell us about the tie, please.
Well, the tie at the bottom, it says Wiley Society, a quest for excellence, and that refers to Jack Wiley. And he, of course, with the meeting we had in Boston, with Dos Santos, which we just talked about briefly, that led to a Wiley dinner during the meetings, and then finally the Wiley Society. And one of our colleagues at UCSF, Tim Shooter, another vascular surgeon and great endovascular surgeon, had this tie made up. So I debated with him whether it should be the aortic arch or the aorta-iliac bifurcation, but
Right.
being he was working in the area of the arch and the great vessels and the aortic valve, we took this one. So that's how that came to be.
It's very attractive. Along these lines, as we wrap it up, is there anything, we've talked rather rapidly and we've covered a lot of territory, is there anything that you would like to bring up for this historical interview related to vascular surgery, or any of your own activities? Are we leaving anything out that you would like to include?
Some of the things that maybe in the area of publications that were important to me or might have impact on other people, and there were a few certainly, and I think the chance to work with Jack Wiley to create the Manual of Vascular Surgery, Volume 1, was a huge opportunity. And then after his death, we put together Volume 2, Manual Volume 2, which was great. And then the other things after that, we got interested in exposure, and David Effie and I did something on comprehensive exposure. Nothing about how to do things except how to create a safe environment to do the actual, whatever the intervention was. And then there were a few papers that I had a chance to write, and one of them I have never forgotten. So I think it was the fourth paper I wrote, and it was a paper with a neurosurgeon, a resident, and I was a resident, chief residence, on an approach to the ventral brainstem through a neck incision. And as a resident, I developed an approach to the base of the brain, the clivus area, by working on cadavers, both fresh, recent deaths, and also the more classic anatomy cadavers, to develop this, I guess you'd say, this pathway to this area. And my neurosurgeon resident, again, none of all the faculty, together we developed the approach to actually remove the clivus area so we could approach the vascular vertebral basilar system of the brainstem. And then on top of that, I say it helped me reinforce in my mind as a surgeon how much anatomy, what a role that plays. And as you develop and mature as a surgeon, you do find yourself at certain times going back to anatomy to maybe look about ways in which you can sort of augment or innovate or modify what has been, sort of, let's say, a traditional thing, and maybe make something come out of it that's even better. So anatomy has been really very important for me. And that operation that George and I did on that 22-year-old boy who had no treatment options left, and today you'd call it compassionate care, then he just said, I'd try anything. And we did this first operation ever, and 1964. And he's alive today, 47 years later.
Oh, that's fantastic. Do you remember how many hours of gross anatomy you had as a medical student?
Well, we were at UC Berkeley for our first year of medical school before going to Parnassus. And we had anatomy part-time all year that first year. Yeah. So that was a great start. And then
hundreds of hours.
Oh, yeah, we had a lot of
this is why I bring it up, because today I just talked to a retired plastic surgeon who teaches our gross anatomy, and we're down to less than 150 hours. And
I would just tell you, because you know this other person, I was medical school classmate of Wes Moore from UCLA, and Wes and I were on the same team to dissect our cadaver, a lady who died of cancer of the stomach. So we both were, it's the first time we got together on it.
well, this has been fantastic, and I think we've had the opportunity to pay homage to Dr. Wiley. As we've said, you were such a team, but this was your interview, and I think we really have had the opportunity to hear many things from you. And the final question we'd like to leave you with is, how do you see vascular surgery, vascular medicine in the 21st century? What do you see ahead? Do you think it's an exciting opportunity for young people or not?
I do think it's exciting. I think one reason I think it continues to be important, continues to be a challenge, because we haven't really solved the vascular disease issue yet. Working on that, of course, in different ways, but I think that's one thing. The second thing is there are more people in the baby boomer population that are entering the age group, but there's also a lot of young people in this world today, particularly in America, that are obese with various diabetic concerns, hypertension, other things that are metabolic syndrome that are leading them into vascular disease at even earlier ages. So I don't think the problem is going away. I think a solution might come from investing in research that can make a real transforming difference in health, but I still think there's going to be a role for the specialty, special interest in treating patients with vascular disease. Absolutely.
Well, we thank you for the very valuable contributions you've made, and particularly for your foundation that will lead into that 21st century. On behalf of the Society for Vascular Surgery, Dr. Stoney, let me thank you. But Ron, great to be with you again, and thank you very much.
Appreciate it. Nice to be together.
Okay,
All right.
Great.